Hello, I'm Rachel Harkness, a PhD student at Leeds University in England, and today I'll be presenting my paper, The Pitfalls of Using Open Data to Develop Deep Learning Solutions for COVID-19 Detection in Chest X-rays, in which we evaluate a popular public COVID-19 dataset termed COVID-X. So I'll start by discussing the background to this issue and our study aims. So distinguishing COVID-19 from other differential diagnoses is a challenging issue and is likely to continue to be an issue for the foreseeable future. However, the current gold standard clinical test, RT-PCR, suffers from poor sensitivity. So with this in mind, the identification of COVID-19 from chest X-rays could be a useful tool to support diagnosis, offering the ability to triage patients and check suspicious negatives. With the sudden and unexpected emergence of COVID-19, there's been a delayed response in the curation and release of hospital datasets. And without the support of these official datasets, there have been attempts to enable AI development through curation of public datasets. With the arrival of accessible public datasets, a huge number of deep learning approaches were applied and reported incredible performance results, some of which even exceeded radiologist level performance. And while reported results showed great promise, due to a lack of hospital data, models have largely gone without rigorous validation. And it's this observation that motivated our study of the use of open data in developing COVID-19 detection models. So as a particular popular data set in this area of research, we focus our study on the COVID-X data set. So like most public COVID-19 image data sets, COVID-X is made up of a number of different sources, some of which were established prior to the COVID outbreak and some of which were established in response to the COVID outbreak. The COVID-X dataset sources non-COVID-19 chest X-rays from a larger pre-existing repository called the Radiological Society of North America Pneumonia Detection Challenge Dataset, referred to as RSNA. COVID-X then obtains COVID-19 chest X-rays from recently released public datasets curated in response to the sudden demand for COVID-related data. So early versions of COVID-X combined 4 COVID-19 repositories. These are the ACMA dataset, Cohen dataset, Fig1 dataset, and the CERM dataset. And as a whole, COVID-X contains chest X-rays assigned to 3 classes: normal, pneumonia, and COVID-19. So the main aim of our study is to investigate the impact of using open source COVID-19 data such as COVID-X. And to do this, we evaluate the performance of 3 COVID-X trained deep learning models on 2 sets of external test data: a custom public test set and a real-world hospital data set. To investigate concerns of bias and confounding, we apply a straightforward GradCam module to evaluate the features that are most important to model prediction. So to conduct a complete analysis of the COVID-X dataset, we take both a data-centric and model-centric approach. In the model-centric portion of the study, we train models on widely used open source data and test them on an external test set and a hospital data set for the task of classifying chest X-rays into one of 3 classes: COVID-19, non-COVID pneumonia, and no pneumonia. In the data-centric portion of the study, we assess the provenance and origins of each image, and we put particular focus on images sourced from the RSNA dataset, which makes up the majority of the COVID-X dataset. So within our data-centric approach, we analyze COVID-X images through visual inspection, as well as through the mapping of COVID-X labels to original sources. Through manual review, we identified a number of potential sources of bias in the COVID-X dataset. CERM, which is a major contributor of COVID-19 images to COVID-X, blindly blends pediatric chest X-rays with adult images and is the only source of pediatric images within COVID-X. So as a consequence, the inclusion of the CERM repository in COVID-X allows models to learn to separate COVID-19 images from pneumonia images using features that are specific to pediatric chest X-rays. And figure 3 shows a side-by-side comparison of pediatric and adult chest X-rays, which clearly demonstrates the associated feature biases introduced with the blending of pediatric and adult images. In addition, manual inspection of ACMED data revealed the common presence of disc-shaped markers in COVID-19 chest x-rays, a feature that is unique to the source of image. As well, the collection of heterogeneous data sets into COVID-X results in the use of images with a large variation in image size. For example, the images from the RSNA dataset are 1024 by 1024, while all the CERN provided images are 2099 by, or 299 by 299. So most models resize the images to resolutions between this upper and lower bracket. So to accomplish this, smaller images must be upsampled and larger images must be downsampled, which risk generating artifacts that might bias the model. Further review identified additional bias introduced by the random application of image pre-processing in the open source COVID-19 repositories COAN and CERN, and the absence of imagery pre-processing in the pre-established non-COVID-19 data sources. So as described earlier, the RSNA dataset is a major contributor of non-COVID images to the COVID-X dataset, and so we've paid particular attention to this data source in our analysis. So when investigating data provenance, we found that the RSNA challenge dataset itself was curated for an object detection task where participants compete to most accurately identify lung opacities and other abnormalities. However, for this task, diagnostic specificity isn't important, and as a result, chest x-rays are recategorized from the original NIH dataset according to radiographical features. And they're categorized into three classes: lung opacity, no lung opacity but not normal, and normal, with bounding boxes available for lung opacity cases. And we noticed that in its compilation into the COVID-X dataset, all chest x-rays from the lung opacity class are included in the pneumonia class. So we can say that the pneumonia class of the COVID-X dataset is expanded to include not just chest x-rays originally labeled as pneumonia, but to include all pneumonia-like lung opacities like effusion, infiltration, and pneumothorax. And as a result, the pneumonia class within the COVID-X dataset contains chest x-rays with an assortment of many other pathologies as well. And so we further evaluate the RSNA dataset to try and quantify the degree of this label misuse within COVID-X. So all RSNA source training data were mapped to the original labels associated with the chest x-ray prior to extraction from the larger NIH chest x-ray 8 dataset. And from here, we're able to identify the proportions of misaligned labels in the pneumonia class of COVID-X. So we found that of the 4,305 pneumonia cases sourced from the RSNA pneumonia challenge dataset, only 264 were originally labeled as pneumonia, meaning only 6.13% of RSNA pneumonia were accurately labeled within the COVID-X data. And we identified the most frequently observed alternative pathologies included in the COVID-X pneumonia data, all of which occur more frequently than pneumonia. So of these, the most common were infiltration, effusion, and consolidation. And while consolidation is a radiological feature of possible pneumonia, it's not a clinical diagnosis. And so we would suggest that the use of consolidation as a substitute label for pneumonia without documenting is potentially misleading. It is also important to note that the normal class of COVID-X takes only from the normal class of the RSNA challenge dataset, meaning all the alternative pathologies contained in the no lung opacity but abnormal class are excluded. And while this is in keeping with what is expected of data within the normal label, expanding the pneumonia class and using only normal chest x-rays rather than pneumonia negative cases greatly simplifies the task, to the point where the end result is an unrealistic data set that's quite far removed from the true clinical problem. So in our model-centric approach of investigation, we evaluate the performance of COVID-X trained models on external data sets with a view of identifying and quantifying data bias. So for this, we required external data, and we created an external test data set made from publicly available data sources. We collected COVID-19 cases from Record and non-COVID cases from Chexpert. We also gained access to hospital data from Leeds Teaching Hospital Trust, or LTHT, to allow us to evaluate on a truly clinically realistic data set from only a single source. So the models selected for this analysis were selected based on publication impact factor and open source data and code availability. And from these criteria, we selected 3 models: COVIDNet, Dark COVIDNet, and CoroNet. All 3 models utilize CNNs for feature learning, while COVIDNet and Dark COVIDNet are standard deep CNNs. CoroNet relies on a 2-stage process to classify images, comprising convolutional autoencoders in the first stage, and then a standard CNN classifier in the second stage. For further details about the models, please look at the original publications, the references for which are included in the bottom of the slide. So here we present the models or the results of model performance on the different test data. Consistent with original reported findings, all chosen models performed exceptionally well for this task when trained and tested on COVID-X data. However, performance dropped significantly when models were evaluated on non-COVID-X data, for which we were more certain of label quality. So we see steep drops in model performance across all metrics. Evaluation of LTHT test results in particular demonstrates that COVID-X trained models are unable to separate classes when applied to clinically realistic data. So poor model generalization combined with our earlier analysis of the COVID-X dataset suggests that COVID-X trained models are unable to learn clinically relevant features that are representative of the general patient population. So to further investigate why this was happening, we looked at the features the models used to predict the class of a given COVID-X image. So for this, we applied GradCam, a standard approach for model interpretation. We do this to identify the most important features in the correct prediction of COVID-19 positive chest X-rays. So on this slide, we present class activation maps. These are heat maps that represent the significance of image features in model prediction. For the correct classification of COVID-19 images from the COVID-X test set, we can see that the model appears to be arriving at this class using features dispersed outside the lung region and in non-anatomical space. And we see a recurring pattern of these features being focused on over diffuse opacification of the lung fields that would be typical of COVID-19 infection. So we can identify multiple sources of bias in these saliency maps. For instance, we observed that the models consistently considered text in the corners of the chest X-ray as important in their predictions, which suggests that the deep learning models may be relying on features specific to a certain type of image acquisition. We also observed a focus on bony structures like the collarbone. So bone density reduces as a person ages, so interest in the collarbone area may suggest the model relies on surrogate age-related markers to make COVID-19 predictions. So to conclude, our analysis of the COVID-X dataset showed misuse of data labels as well as high risk of bias and confounding. The poor performance of deep learning models trained on the COVID-X dataset on both publicly available external test data and LTHT data demonstrates that the exceptional performance reported widely across the problem domain is inflated, that model performance results are misrepresented, and that models do not generalize well to clinically realistic data. Overall, this demonstrates the need for greater and more timely access to clinical data representative of the clinical problem to facilitate thorough model evaluations and solve real clinical problems. Thank you for listening. If you have any further questions, please feel free to contact us at the email address shown on the slide.